Cirrhosis 4 is about the workup for transplantation and hepatocellular carcinoma. We're going to talk about both the things you should look for in your transplant workup and HCC. To begin, we're going to start off by readdressing the MELD. A MELD score is how we rank how sick a liver is. It is made up of the creatinine, the T-bili, and the INR. You can be transplanted at 15. You were at death's door at 40, and our country usually transplants patients in between 28 and 32. The thing is, the sicker the patient, the sooner you get your liver. The problem with that is after transplant, because they were so sick before the transplant, their morbidity and mortality is very high afterwards. So, you follow the MELD in order to determine how sick they are and how soon they'll get the liver. Because there are more liver patients than livers available, you want to make sure that you don't waste a liver on someone who cannot sustain it. So you're going to do a number of tests. First, you're going to do, in someone who has cirrhosis, hepatocellular carcinoma screening. This is in people who are on the transplant list and who aren't. In order to perform hepatocellular carcinoma screening, you're going to get an AFP and a right upper quadrant ultrasound every 6 months, because hepatocellular carcinoma can be diagnosed without tissue biopsy with an elevated AFP and a mass found on ultrasound. As part of the transplant workup, you want to determine whether or not this liver has any hepatocellular carcinoma in it. You can still have HCC without an elevated AFP. So as part of the transplant workup, you are going to get them a triple phase CT. What does triple phase mean? It means early arterial, late arterial, and venous. Let me show you why this matters. Here is the liver. Here is the hepatocellular carcinoma. Most of the liver receives its blood supply from the portal vein. Whereas the hepatocellular carcinoma receives most of its blood supply through angiogenesis through the hepatic artery. Such that when you inject contrast during the CT scan, what should light up in the early arterial phase is that which has a lot of arterial supply. That which lights up in the venous phase should be that which receives most of its blood supply from the venous system. So you temporally separate when you take the image based on the administration of contrast. Specifically, what you'll see is a bright cancer with a dimly lit liver during the early arterial phase. And then that lesion, the cancer, is going to quote-unquote wash out. You are going to have a bright liver that excludes the area where there was a cancer on the early phase during the venous phase. What lit up, what's marked in red scribble, what lit up was what was being supplied by the phase. The liver lights up in red during the venous phase because it is supplied by the venous system. Hepatocellular carcinoma lights up during the early arterial phase. It has red scribble during the early arterial phase because it has its supply from the artery. It washes out in the venous phase and you can't see it anymore because most of its vascular supply is from the artery. So if you find a lesion in the liver and you do a triple phase CT scan If there is washout, it's hepatocellular carcinoma. If it doesn't wash out, it's something else. It could be a metastasis, it could be a hepatoma, it could be nothing, but it is not HCC. So the way you screen every cirrhotic for cancer is AFP and right upper quadrant ultrasound. The way you screen people being prepared for transplant is a triple phase CT. Some of the other things you're going to get are things like a 2D echo with bubble study and a right heart cath. The 2D echo with bubble is for hepatopulmonary syndrome. Hepatopulmonary syndrome has the following pathogenesis. We know that the liver wins, so that there is peripheral vasodilation. There's also vasodilation in the pulmonary arteries. A normal alveolar capillary exchange looks something like this, with a red blood cell that can barely fit through, so that there's very little diffusion barrier for oxygenation. In hepatopulmonary syndrome, there is a shunt. There's such vasodilation that the alveolus capillary exchange is grossly changed. Now, it may not seem like a big deal, but just this small difference makes a difference in oxygenation. This is a longer diffusion barrier for oxygen to get from the alveolus to the red blood cell than this is. Thus, the patient is going to present with hypoxia. But it's not just hypoxia. It is going to be hypoxia when they're upright. They have what's called platypnea. This is the opposite of someone who has heart failure, who has orthopnea, who gets worse when they lay flat. The person with hepatopulmonary syndrome has platypnea. When they sit up, they become more hypoxic, and it is a product of the vasodilation and the zones of the lung which preferentially give blood flow to poorly oxygenated areas. When they sit up, the condition makes them more hypoxic. When they lay flat, they are no longer hypoxic. The test for this is a 2D echo with bubble. You take agitated saline, just literally a vial of saline, and shake it up and inject it into their vein. What you're looking for is both the patent foramen ovale and hepatopulmonary syndrome. What should happen is the pulmonary vasculature should be very tight at the capillary, such that those bubbles can't get through. They get trapped in the capillary and get absorbed. But what happens in hepatopulmonary syndrome, because of all this vasodilation, bubbles are allowed to make it through. So if you see bubbles after 3 to 6 beats, that is hepatopulmonary syndrome. If you see bubbles on 1 to 2 beats, that is a patent foramen ovale. The treatment for hepatopulmonary syndrome is transplant. And actually gives them bonus points on their MELD. If they're already less than 22, they get brought up to 22. But hepatopulmonary syndrome is not the only thing the liver can do to the lungs. And this gets frustrating because the liver can also have hepatopulmonary hypertension, the opposite of hepatopulmonary syndrome. The mechanism is not well understood, but if you have pulmonary hypertension for any reason, whether or not it's the liver or from our pulmonary hypertension lecture, it precludes the person from getting a liver. The way you work someone up for hepatopulmonary hypertension is with a right heart cath. The right heart cath assesses the pulmonary artery pressure. And you can try to do the therapies we talked about in the pulmonary hypertension lecture, things like Revatio, Remodulin, or Bosentan, or any of the other experimentals. The reason why you cannot give someone with hepatopulmonary hypertension or pulmonary hypertension in general a new liver is because what you do is essentially take this bad liver with a whole lot of venous return, with a very narrow IVC. And when you replace the liver, you take all this venous return and you just dump it back into the right ventricle. If the right ventricle is not used to having that much preload, the right ventricle fails, fluid backs up, and that new liver is killed. Because all the pressure is translated directly into the liver, and you get a congestive hepatopathy, which kills the transplanted liver. So if you have pulmonary hypertension from any cause, hepatic or otherwise, diagnosed by a right heart cath, you can try to reduce that pulmonary hypertension, but generally it precludes them from transplant. The last test you're going to get in anyone who's undergoing transplant surgery is a left heart cath. Why do you do that? Because you want to make sure they don't have coronary artery disease and they're going to die on the table, and that they can actually survive long enough to use the liver. So in order to work up someone for transplant, it's going to be a triple phase CT, 2D echo with bubble study, right heart cath, left heart cath, and of course you're going to have the diagnoses of hepatic encephalopathy or ascites, varices, etc. I'd like to close this lecture by talking a little bit about hepatocellular carcinoma. Let's talk a little bit about hepatocellular carcinoma and how it influences transplant, because it's interesting the way this works. Hepatocellular carcinoma. The first thing you need to know is the Milan criteria. And the Milan criteria says 5 and 1, 3 and 3. That is, you can have a single hepatocellular carcinoma that is 5 centimeters in size and still get a transplant. Or you can have 3 lesions that are no bigger than 3 centimeters and still get a transplant. If you have more than 3 or any one greater than 5, you cannot have a transplant. Sort of. Because if you're outside the Milan criteria, you can still have interventions to destroy those cancers or shrink them and bring you back into the Milan criteria. That is, once you are excluded, you can have therapies that then re-include you to transplant. What I want to go over is a chart, a diagram of what the potential interventions for hepatocellular carcinoma are in getting people transplanted. Let's start off with the extremes of hepatocellular carcinoma first, because it makes the most sense. What happens in between is a little difficult to tease out. You have hepatocellular carcinoma. The first thing you do is actually grade them on the child's Pew score. And essentially the child's Pew is another way of saying how sick they are. If they're child's Pew A, that is, they're really healthy, you're going to try to simply cut out the cancer and let them continue. This is hepatocellular carcinoma, whether cirrhotic or not, but we're going to try to tie it into the cirrhosis. If they're child's Pew C, that is, they're really ill, it doesn't matter how many lesions they have, they're going to be set up for hospice. Because child's Pew C patients are so sick, they're not likely to recover, and they should just go home. But in order for child's Pew A, someone who's doing very well, to receive just a resection, what you're looking for is only one lesion that's also small, and they have normal portal pressure. If small lesion, only one lesion, and normal portal pressures, this person can receive a resection. So if they're doing really well, little lesion, no big deal, it gets cut out. If the patient is really sick, it doesn't matter, they get hospice. What happens in between is a little convoluted, and I'm going to try to portray it in a way that will help you remember it. If you're in between, that is going to be child's Pew A or B, you separate the patient into 3 categories: advanced, intermediate, and early. If they are in the advanced stage, that is, there are metastases, or way outside Milan because there's like 75 lesions, this person gets sorafenib. Chemotherapy without any hope of re-entering Milan and getting a transplant. If the patient is intermediate, there's not a really good classification of what that means, but you'll see that it is not A with one lesion that's small, and it's not early, and it's not advanced. If it's intermediate, these patients get TASTE. That is chemoembolization. However you actually get in there to give the chemoembolization, which is the TA part, you're doing chemoembolization. You're trying to kill the cancer to shrink it or get rid of it to move the patient closer to transplant. Here's where it gets the most convoluted. This makes sense. The person who is very ill gets hospice. The person who's really ill gets palliative chemotherapy. The person who's pretty close but probably outside of transplant gets TASTE. But inside this early phase is where the criteria start to get jumbled up. And it's either going to be straight up transplant or radiofrequency ablation. So you have to figure out who gets radiofrequency ablation and who gets transplanted. And the idea is these patients will never see transplant. These patients might. And hopefully you'll feel that the bigger and badder the lesion, the more likely they are to get chemotherapy, and the smaller the lesion it is, the more likely they are to get radiofrequency or transplanted. So just follow with me. If you have that understanding, that's good enough. You can walk away from the lecture. But if you want to know the details, here they are. If they have 3 lesions that are 3 centimeters, or the lesions are large, or elevated portal pressures, even if they're just Child-Pugh A, you have to decide, do they go to transplant straight away, or do they go to radiofrequency ablation? And the idea is, if they're inside the Milan criteria, 5 and 1, 3 and 3, transplant. If they are not 5 and 1, 3 and 3, then you burn those cancers away until they are 5 and 1, 3 and 3. So let me just go over it again one more time. If you're really sick, you get hospice. If you're mostly sick, you get chemo. If you're sort of far away from transplant, you can try this, but really it's more palliative than it is getting you to transplant, but you might get someone who's TASTE into the 3 and 3, 5 and 1. If you are close to 5 and 1, 3 and 3, you get radiofrequency ablation, making you transplantable. You get transplant only if you have 3 and 3, 5 and 1, and you pass all of the other transplant screening we've done. Unless you are super healthy and you are so far from transplant because you don't need a transplant, you can just cut out the cancer and call it a day. So really healthy gets the cancer resected, really sick gets hospice, and you have to sort of tease out who gets TASTE, radiofrequency ablation, or transplant. And generally it's a lot of tumor or really big, some tumor not really big, few tumors small. All right, one more time to review the lecture. We talked about the transplant workup for someone who has cirrhosis with an elevated MELD. We know that the presence of hepatocellular carcinoma makes them more likely to get transplant so long as they stay inside the Milan criteria. If they're not in Milan, then you can do things like TASTE and radiofrequency ablation to get them into Milan so they get transplanted. That is cirrhosis for transplant.
We make these videos for free, and we need your help. Please donate, because without your donations, we can't make any more videos. Please donate.